the recording. So thank you.
Thank you. So hi everyone. Today we're
Okay.
here with so today we're here with Dr. Seth Flaxman. Thank you so much once again for your patience and attention for us. So Dr. Seth Flaxman is a professor at the Department of Mathematics in Oxford. He also helps the Machine Learning Initiative at Imperial and also for the EPSRC Center for Doctoral Training in Modern Statistics and Statistical Machine Learning at Imperial and Oxford. Completed his PhD at Carnegie Mellon University in August 2015 in a joint program between public policy and machine learning. At Carnegie Mellon University, he was a member of the SML Lab and the Event Pattern Detection Laboratory. He spent the summer of 2013 at Microsoft Research in New York City in the computational social science group and was visiting statistics at the statistics department at Columbia University during the academic year 2014 to 2015. He has also worked at the World Health Organization in the Mortality and Burden of Disease group in the Department of Health Statistics and Information of the Global Burden of Disease project and the Nutrition Impact Model study. He has continued to collaborate on research with the Global Burden of Disease and WHO researchers. And for those here, he is also as a younger student during his final years of high school, also attended some science fairs, including London International Youth Science Forum. So that's all very interesting material for us to discuss with Dr. Seth Flaxman today. So thank you all very much for attending and for those watching on YouTube. So the stage is yours.
Okay, so thank you so much. So I'm going to be telling you today about my work during the pandemic primarily. And one tiny correction, Department of Computer Science at Oxford. Understandable confusion. I was in the Department of Mathematics until a couple months ago at Imperial, but I am now in CS here at Oxford. Okay, so let's get to it. So yeah, computational statistics and machine learning is what I do. And so I'm going to tell you about some of the computational statistics and machine learning challenges, approaches, methods, new things we've developed during the COVID-19 pandemic. Okay, so you already heard about me. The last thing to add is from Evanston, Illinois, a suburb of Chicago. Participated in the London International Youth Science Forum, we think in 2004, after I finished secondary school. And in some ways, the work that got me there was about physical models and computer simulations that match them. And what I'm going to tell you about today is not that different. Okay, so I'm going to tell you about our COVID-19 work. This is all a big collaboration. I'll show you some of the names of the collaborators and where they are. And then, as I said, computational statistical and statistical machine learning challenges and lessons that we've learned. So here's an incomplete list of the collaborators. I'm waiting for people to tell me, people I've forgotten, but there are people I've forgotten because there are new people all the time who are starting to join us for various projects. And so in fact, looking at this list, I have forgotten our collaborators at the Centers for Disease Control and Prevention in the United States. So big recognition to them. And for that matter, I've forgotten collaborators at Harvard. So okay, got to update this slide. But at Imperial College, which is where I was until a few months ago, is the biggest group. And then followed by Oxford, where I am now. And then we have very critical and important collaborators in Brazil and India. And also help with web design, which I'll show you that website in a second. Collaborators in Brazil and India have been, important for the science, but also for collecting and sharing data, critically important data, often under difficult circumstances. So running surveys, seroprevalence surveys that measure how many people have been infected in the past, running those surveys in the midst of lockdowns across multiple cities in India is amazing, invaluable data that then I was privileged to help to some degree with the analysis of. So major recognition of INSACOG, Indian SARS-CoV-2 Genomics Consortium, New York State Department of Health that we worked with throughout, and in Brazil, Professor Esther Sabino and her lab. Okay, so what has been our work. So in 2020, starting in March, we were looking at the impact of non-pharmaceutical interventions. Of course, there were no vaccines, so this was non-pharmaceutical interventions. There were barely any well-understood treatments at that point, right? And so lockdown, social distancing, school closures, work from home orders, things that we still see today. Austria has just announced a strict lockdown. Those were the only tools that were available, and countries across Europe were putting them into place in different orders and with different definitions, and we were trying to evaluate the effectiveness of those non-pharmaceutical interventions using statistical disease models. And I'll try to tell you what I mean by both of those modifiers of the word model. After that, shortly after that, was work bringing what we had done across 11 countries in Europe to the subnational level in Italy, Brazil, and the United States. And having done the work early in Brazil meant that by the time October, November, December came around in Brazil, and we were hearing rumors that there was a second wave happening in places that had been very, very, very hard hit in the first wave, we were well placed. We also had the collaborators to be able to try to figure out what was going on. And so I'll show you that in a second. That's 2021. Other important work in 2020 was a paper. First author on this paper is a current PhD student at Imperial College, Melody Monod. So full recognition to the contributions of students, not even necessarily senior students. I think she was in her second year. And so this is published in Science, one of the best journals, and it's about which age groups in the US were driving the spread of COVID, and looking at, in particular, 18 to 45-year-olds, working age adults, 24, I believe, to 45-year-olds. And that is important for policy. That's important for understanding what is going on. It's important for forecasting. Okay, that was 2020. 2021, really starting in December of 2020, was variance. So the first paper, we didn't have a name. We didn't have a convenient name for it at that point. B117, that was the alpha variant. And so the first hardest hit place by alpha variant, because it arose almost certainly in the UK, is England and Southeast England, where I am. And so we have a paper characterizing the properties of the alpha variant B117, then not really follow up, different work, but on another variant, P1, so-called gamma variant, in Brazil. And so that was what I was just alluding to, that there was a resurgence in Brazil. I think I'll show you a plot of that, which was unexpected. People thought, well, Brazil has reached the herd immunity threshold because so many, in some cities, not all, but in a place like Manaus in the Amazonas state, so many people have been infected. Unfortunately, so many people have died. There shouldn't be another wave. And this is what people said in Brazil. They were wrong. This is what people said in India. They were wrong. And so we also have papers on Delta in the UK, a very prescient paper on Delta in England, and then 2 papers in India. More recently, some work that I hope I have time to talk to you about, well, we'll see how far I get, on estimating the number of children who have lost parents or caregivers. And so this has been, we think, a very overlooked issue. There's very little work on it. And we have country for every country in the world, global estimates for every country of the number of children who've lost parents or caregivers. And then we have subnational estimates for the United States. And those have both been published in the last 6 months. The numbers are huge. Numbers are shocking. I'll show you our website that keeps that up to date. And then finally, we have a paper forthcoming on big surveys, big data, and what's called the big data paradox. And I think I'll have time to tell you about that. This is a surprising finding that really, really big surveys, 250,000, can very significantly misestimate estimates quantities that we want to estimate, like what percent of the US adult population has had a first dose of the vaccine, and very, very, very confidently misestimate. So the confidence intervals, the margin of error is minuscule, and the estimate is just wrong. And so we'll talk about that if we have time. Okay, so there are some websites. Let's click on Austria because that's the one built by a collaborator, and that one is interesting today. So Austria announced a week ago a lockdown for unvaccinated people. It announced today a lockdown for vaccinated people and a plan to make vaccines, a lockdown for everyone, a plan to make vaccines mandatory. And maybe we can see why they're so worried. So hotspot 50, well, that's weekly projected cases per 100,000 above 50. Well, yes, certainly above 50, it's been blown through for weeks. Above 100, well, yeah, also above 200, above 400, above 500. Okay, so there's a few regions where probability is low that it's above 500. Let us look at Vienna. Oh, what state is Vienna in? I don't know. Okay, well, let's just pick a hotspot. Here's the worst hit place, I believe. Probability that R, the effective reproduction number, time-varying reproduction number R is greater than 1 is 100%. Why is that? Because this is the growth of cases, yeah? So over the summer of 2021, very, very few cases reported, maybe none, and then things have just shot up, yeah? And so in order for them to have shot up that quickly, well, almost certainly it's Delta that's driving it, and Delta has increased transmissibility. Perhaps it's also the fact that Delta can infect people who previously were vaccinated or previously infected, something that we have argued, and that other people, of course, have provided estimates for. And possibly, people who have been infected post-vaccination can infect other people. And that's something that we hope would not happen, that we didn't see as much with previous lineages with alpha, with the wild type. And so here is an estimate of the time-varying reproduction number. And so, yeah, that's huge, really high. And that's what's driving this. Now, in this plot, we don't see anything, is it going to go down? I mean, at some point there's a lockdown. And so on Monday, there's a lockdown. So that will drive almost certainly the time-varying reproduction number below 1. And we know that now because we've seen it happen. What happened on October 26th in Austria? I don't actually know. We have to look it up. But presumably last year, there were stringent interventions if there was this sort of change. And actually, I don't know. I don't know about Austria. But we can see it in the UK data. Let's go to the UK. UK also on fire. But there are places where things are decreasing, perhaps because of acquired immunity through natural infection. Not the reason we want things to decrease, but at the rate things are going in the United Kingdom, it's sort of inevitable. Let's go to Oxford, where I am. I haven't actually looked at this recently. Sort of terrified to look. Cases are absolutely exploding here among young people. Okay, so the time-varying reproduction number is nowhere near as high as it is in Austria, which corresponds to the fact that cases are growing, but not doubling every week. They're increasing by 10 or 20% or something like that. And yeah, let's go back in time. So this was not a lockdown. This was the, we still don't really know. This was Euros 2020, schools closing, pingdemic, lots of interesting things happened there. Oh, and we can't go back. This might be my fault. We can't go before February, so we can't see what our estimates were. But in January, when there was a strict lockdown, you could see that the time-varying reproduction number was driven below 1. So, okay, so that's just to give you some sense of where this all ended up. Now I'll tell you again about the statistics. Maybe I'll come back to orphanhood. Okay, so this all started in March. It all started with a collaboration between me and members of the Imperial College COVID-19 response team. And what we wanted to do was to build on the work of somewhat famous, of Report 9, Neil Ferguson and my colleagues. Neil was also my colleague, which was not a statistical model. It was a disease model. It was a model that made scenarios, forecasts, but you want to call them scenarios because they're not truly forecasts. And the point of those was to say, here is what might happen without intervention by governments, without stringent non-pharmaceutical interventions, without lockdowns. Here is how many people might die. And those predictions, those forecasts, those scenarios were very influential in changing policy in the United States and the United Kingdom. A few weeks later, we started the work immediately, but we released as a report at the end of March, we were already able to say what has been the effectiveness of these non-pharmaceutical interventions. So Austria, we were just talking about, Austria brings in case-based self-isolation mandated. So you might not remember this, but there was a time when if you had a cold and a high fever and a cough, you didn't need to stay home. If you can power through it, if you can go to work in your retail job, why not? Go for it. And, by March of 2020, people were realizing that's a horrible idea. These people need to stay home. They need to be isolated from themselves, from their families, from society, and hopefully that might take things into, get things under control. Of course, it did not on its own. Social distancing encouraged, that's a pretty broad one, but that's basically work from home. Public events banned, that's something that we saw in every country. UK and Sweden were pretty late to the story with that, and that's something that you can see in the data. Schools being closed, of course, very important. And then mandatory lockdown of varying stringencies. Somewhat famously, Sweden is missing from here. And we can talk about that if you're interested. We got a lot of criticism for our treatment of Sweden, with people claiming, oh, Sweden never had a lockdown. Sweden had a not exactly as stringent, not exactly as required by the government lockdown, but people changed their behavior similarly to in other countries, but not quite as quickly and a little bit later. And I mean, you can see all of that in the data. None of it's really a surprise. It was just, well, anyway, it's a different argument. Okay, so that's the setup, and that's the data. Yeah, these are the covariates. So we code these as zeros and ones. So Switzerland brought in case-based self-isolation on 2nd of March. And so that's coded as a 0 beforehand and then a 1 afterwards, similarly for all of these. And so if you're going to use this in a regression style framework, you're going to immediately worry about something called co-linearity, because all sorts of interventions are brought in quick succession or simultaneously. The UK had a lockdown, but it also had public events banned. We can't identify cleanly, specifically, the effect of a lockdown if it also always comes with public events. But some countries had a lockdown in Italy and public events banned a few days earlier, but that's probably not enough days to tell the difference, right? Because there's a progression of an intervention comes into a place, people follow it, usually immediately. If schools are closed, no one goes to school the next day. But then what is the effect on transmission? For that to show up in cases takes, a week, maybe 4 or 5 days at the fastest. For it to show up in deaths, well, that takes 3 weeks. And so we were trying to quantify these effects in March when we had only seen 2 days of data for the UK. We had seen a lot of days of data for Italy. And so how could we possibly do that? The answer is that we built a statistical model which wrapped around a disease transmission model. And in that way, we were able to infer effects borrowing strength across these 11 countries. And I think that this is a very underutilized approach. It's similar to meta-analysis. And so certainly meta-analysis is a very popular and widespread approach in statistics, medicine, epidemiology, biostatistics, but it has not been as exploited as it should be, as utilized as it should be within epi, I would say. And even just the idea of learning from other countries hasn't been, why did the UK wait until the 24th of March? What evidence did the UK need? The UK could see what was happening in Italy 2 weeks earlier. Yeah. And there was no reason to think, the UK was different, that, people in the UK were better at washing their hands, that would be more effective. So learning from other countries has been an underutilized, underappreciated approach during this whole epidemic. Okay, so here's the model. So we have these non-pharmaceutical interventions that I told you about, country specific. They directly affect R, the time varying reproduction number. R is parameterized using R naught, the basic reproduction number, and then these things modify it. They can make it higher, but using a prior in the Bayesian sense, we are a lot more confident that they make it lower. And what is the reproduction number? Well, it tells you if one person is infectious, on average, how many people do you expect that they will infect during the course of them being infectious? Under specific theoretical assumptions that we don't think actually hold, a well-mixed population, which, we don't have people live in social networks, people live in households, people attend workplaces and schools. So we don't have a fully well-mixed population, but that's the model, and that's the way to keep things simple. And that simplification in various ways isn't a limitation. At least we hope it isn't. And so it's worth checking that in various ways that at this point we weren't able to do because of the data that we had. What is the data that we have? I told you about this. The only other piece of data we have is observed death counts. Now, people were trying to use another source of data, case reports, observed cases. And that, it turns out, was, I would argue, a mistake. We haven't fully gone back and seen, well, could we have done this all based on cases? But there's contemporaneous papers that do it based on cases, and I would argue that our estimates are more robust than theirs. Why? Cases testing was severely limited in February and March, yeah? Certainly in the United States, this is about Europe, but the United States was a great example of just, there was no testing available for weeks and weeks and weeks because of various political problems. In the UK, they stopped doing testing because they didn't have the capacity for it. And so the people who are getting tested are people who show up in hospital and a doctor is able to order a test for them and needs the result of that test to be able to provide treatment, yeah? Or you know, if you had contact with the health minister, maybe you got a test because it's important to know if you infected the health minister. But testing is not available in any sort of representative way. And so using reported cases, well, there's another problem with that, right? Asymptomatics. If 30% of people are asymptomatic, they're never going to get tested. Nowadays, maybe with cheaply available lateral flow tests, you might have more coverage of those people, but again, those have lots of false negatives. So we use death data. That's what we use because we thought it was reliable. It's not perfect, right? Plenty of people don't get reported as dying, and under ascertainment, under reporting becomes a real issue when you see healthcare collapse. So in places like Brazil and in India, estimates of under ascertainment, under reporting can be, you know, a factor of 2, a factor of 5, a factor of 10, which is incredible. Okay, so how do we get from the time varying reproduction number to observed deaths? Well, we have a disease model. This part is statistical. We're trying to learn a coefficient beta that tells us how effective is lockdown, how effective is banning public events on changing the time varying reproduction number. Given a time varying reproduction number, we can use that to drive a disease process, a latent process of modeled infections. So if I have one person who's infectious, one person who's infected and is infectious, well, if R equals 3, then we expect that within some period, given by the serial interval distribution, or the generation time distribution might be the right name for this, within some period, I will end up with 3 people infected, 1 person to 3 people, so 4 infections total. Now, what does 4 infections total mean? Nothing. Those 4 people might be healthy. We might never see them, right? They might be, you know, slightly sick. They might be very sick. They might end up at hospital, but there's no hospitalizations in this model. People have added it later. We've added it later. Those 4 people, maybe nothing happens. But if we have 400 of them, well, probably a few of them will die. And so let's say that the process goes for a week or 2, and then we end up with 400 people infected. Okay, now, given the population average infection fatality ratio, something that was very controversial in February and March, maybe still is. But we use estimates from our colleagues, which were the best available at the time, unless you were sort of a conspiracy theorist. Those estimates said something like 1 in 100. Yeah, now this can change depending on age structure, so that's why it's population average. It can change depending on contact structure. So if grandkids spend a lot of time with grandparents, that will potentially increase the IFR, the infection fatality ratio. And so we take all of that into account and we come up with a number for each country. So maybe 1% of infections end up as deaths, yeah? And so that's how we go from modeled infections to modeled deaths to observed deaths. And then there's a likelihood, another part of the probabilistic statistical model that goes from modeled deaths to observed deaths. Okay. So what's special about this model? Once again, it's got a disease model in here. It's got parameters that we can't estimate, that we take from someone else, infection fatality ratio, generation time or serial interval, and also the time lag. What is the time from infection to symptom, symptom to death? And that's important because we see the data. Now, people make this mistake still. Certainly, they were making it a year and a half ago. We had a lockdown. Why aren't deaths going down? It takes time. It takes 20 days on average to go from changes in the reproduction number to observed deaths changing. And so we should not expect to see evidence that the curve is flattening necessarily immediately. We should see some evidence after 5 days or 10 days or 15 days because we don't expect the curve to get even worse. And that's why we wanted a model that could share strength across countries. And so that's a very important statistical, Bayesian statistical aspect of this. Okay, so I've got model details in stand code. I'm not going to show them now, but if anyone's interested to see sort of like how do you actually implement this in a probabilistic programming language called stand, how do you turn the mathematics, the probabilistic statements into stand code, which then gets compiled to C++, and then you can infer parameters. I'm happy to show that. Okay, so here is what the model looked like at the end of March for the UK. Now there's very, very, very little data here. This right here, this is deaths. Here's deaths, yeah? This death curve is increasing. You know, for all we know, there were 125 deaths or something like that. It could keep going up and up and up and up and up and up and up. Eventually it's going to go down, right? Eventually you will, in fact, if there are no interventions whatsoever, something like 70% of the population, and having infected 70% of the population, 1% of them will die. So 0.7% of the population will die. Yeah, so that's a very naive, crude way to see that this curve can't go up forever. But maybe, hopefully, the interventions that have already come into place, self-isolation, social distancing, school closure, complete lockdown, and public events ban, maybe all of those will slowly make, or hopefully quickly when it comes to lockdown, RT below 1. And if RT is below 1, then the epidemic is no longer growing. Now, how could we possibly infer these things given that we only have one country here? Well, this is the results of fitting the model to 11 countries. And so the United Kingdom is able to infer effects from Italy, which had experience that was 2 weeks ahead of the UK. So having 3 weeks of data from Italy, we hope that we can start to inform ourselves that maybe a complete lockdown is effective. Now here, the probability that R is below 1 is actually, not very high. We don't have that much data. It's pretty worrisome, but let's play the story forward. As we accumulate more and more data, the Bayesian posterior concentrates around what we are pretty sure is the truth. Lots of other evidence has supported the idea that the time-varying reproduction number really is below 1 by the time we get to the post-lockdown period. Now, we've had lots of criticism of this plot because it looks like these interventions don't do anything, and this one is the only one that matters. And that's not fair, but I understand the criticism. I wish there was a better way to have explained or to have shown what we did. And in retrospect, we have come up with better ways. But at the moment, we were trying to understand, does social distancing work? And lockdown is the most stringent of them, and it clearly had the biggest effect in our data. But we couldn't distinguish between the other ones. And so the problem with this model, with this picture rather, is that it looks like we have distinguished. We've said only lockdown works, but actually these other things might have started to drive it down. But the way that our model shows things, because it's a simplified model of reality, it shows that actually only lockdown drove it below 1. But in fact, I think that's true. I don't think that the UK without lockdown would have controlled the epidemic, at least until so many people were taking behavior changes on their own, and so many people were infected that was depleting the pool of susceptibles. So in some sense, I'm perfectly fine with this. In another sense, I'd like this to be smoother, and I'll show you why we can't distinguish with the data that we have in a minute. Okay, so this is death data. This down here, you can't even see it. These are the cases that are reported. So there's a really good reason we didn't use cases. Very, 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 very few cases were reported in the period we cared about. And yeah, okay, by April and May, we're getting to see some cases, but at that point, it doesn't matter. So it was important that we talked to epidemiological experts and that they told us, you can't rely on cases. You got to use deaths. So that's lesson number 1. Rely on domain expertise and domain experts. Experts can give you priors, they can suggest mechanisms, they can tell you about causality, but they don't know about your model, right? That's up to you. So they can't tell you, oh, your model is going to be able to identify this, or it isn't. They're not used to thinking about that necessarily. And so you got to be careful. So some people wanted, and I'm sure I tried it at some point, wanted the infection fatality ratio, what fraction of people who are infected die, wanted to infer that from the data that we have here from deaths. But you can't. There's nothing identifiable about that. This curve here could be increased by a factor of 10. 6 million people could have been infected, or decreased by a factor of 10. 60,000 people could have been infected. And both of those would be consistent with this death curve for different values of the infection fatality ratio. And so the model here is not going to be able to inform you that 1% is right. It could be 0.1%. And there were people who thought, infection fatality ratio for SARS-CoV-2 is actually 0.01%. 0.01%. Now, that was a ridiculous claim to make in March of 2020, but you can understand that people were being really hopeful. Maybe everyone's been infected and only, a couple thousand people have died. Wouldn't that be great if this whole thing was over? By the time we have a second wave, a third wave, a fourth wave, and a lot more people have died, 750,000 in the United States, well, it doesn't make any sense. If you multiply by 0.01%, or I guess in this case, divide by it from 750,000, you get more, you get the idea that everyone in the US has been infected more than once. It just is farcical, but that was what people believed at that point, and they were being hopeful, but also promoting nonsense. And anyway, okay, so here is a different story. Same model, but it's parameterized differently. So we've still got within Piedmont and area of Italy, we've still got the interventions here, but they're not actually what's parameterizing the model. What's parameterizing the model is mobility. Here, I'll show you mobility. So average mobility change from baseline. So baseline before COVID is on the scene, before people are aware it might be spreading in Italy, baseline is 0. And then as these interventions come in, so the first intervention is on 24th February. So when people become aware that something is going on, there is a drop in mobility, but it's not a very big one. So public events banned, schools and universities closed. Okay, so maybe people are going home because their schools and universities are closed, spreading it to rural regions. But then we get here for a couple weeks until lockdown. And here you can see, this is why it's a little crazy that people have questioned the effectiveness of lockdown. Lockdown meant that people stopped moving around. Italy had a very strict lockdown. People were not allowed to leave their house, or only allowed to leave their house under certain conditions, or only for an hour a day. I don't actually remember the details, but it was very strict. One of the strictest in the world. Maybe not as strict as Wuhan, maybe as strict as Wuhan. And so that's the effectiveness of lockdown on mobility. This is Google data on mobility. So we use, instead of lockdown, instead of the zeros and ones, we parameterize the time varying reproduction number using mobility. And so as you can see, the time varying reproduction number is some scaling of this. And then the only thing the model needs to sort out is, well, when does it go below 1? Yeah. And so it goes below 1, well, around the same time that we already said it went below 1, around the time of lockdown. But this is a little bit smoother. Yeah, it's not a drop immediately. And so there was this question like, well, did we get it wrong? And so I'll come back to that. What I know we got wrong with these scenarios, not forecasts, not predictions, but scenarios in the report that we released on Italy, was we said, you know what? If after Italy reopens on the 4th of May, 2020, if, this is why it's a scenario, if the time varying reproduction number goes above 1, if mobility increases by 20% and then the time varying reproduction number goes above 1, then we're going to see deaths, which were decreasing about 2 weeks later, start to increase. Yeah. And this is wrong. This is not what we saw. Deaths did not increase in Italy until the autumn. So how come these scenarios were wrong? In fact, mobility did increase. So this is reopening, and immediately, the day that Italy reopens, mobility increases, and it increases more than we thought. It goes back to this high baseline until the autumn when things get bad. And so what happened? Well, a number of different things happened. The most important is that after lockdown and all of these interventions were brought into place, the exact relationship, which we parameterize as linear between mobility and time varying reproduction number, that relationship is no longer linear, or maybe it's still linear, but it no longer has the same coefficient. And that's because of all sorts of other interventions and changes to the world. So face masks, social distancing, ventilation. It's May in Italy, so people are doing more things outdoors rather than indoors. And changing structure of who's getting infected. So perhaps cases are starting to rise. I don't think that I have. Here we go. I have cases. So no, they're not. They don't start to rise until August. But in other cases, we see this. Cases start to rise, but among young people, and so that doesn't translate to deaths. So there's all sorts of things that our model doesn't take into account, which is fine in some sense. I mean, if we were making this very strong prediction and we were arguing Italy shouldn't open up, which we didn't argue, we argued that Italy needed to carefully monitor the situation, and they did. And at this point, we maybe can start looking at cases because they're so low in case testing becomes more available. And so by the time it becomes October, well, okay, now things are really worrisome. And the number of cases is much, much higher, but of course you can't compare apples to oranges because testing wasn't available. So we should compare deaths, yeah? And so that peak, the second wave in Italy, another lockdown, well, similar peak. And in some sense, that's too bad. Why didn't we learn anything? Why wasn't there a lockdown sooner? So models are not perfect, of course, right? If a model was the world, then it wouldn't be a map. It would be, that old story about a map that's as big as the world. Models are imperfect, shrunken down, stylized, simplified maps of the world. We don't necessarily need higher accuracy. I do a lot of machine learning, and machine learning, the focus is often on like reducing the mean squared error, increasing the classification accuracy. In this setting, we don't need the most accurate models. We need models that capture things that we care about and that we can understand where they go wrong. Because the point of a statistical model, the point of a model period, doesn't have to be statistical, is to be able to say, where does the model not match reality? Because then we can learn something about the world. Because we have a representation of it, which is wrong. And so there's something that we haven't captured. The coefficient of the time varying reproduction number parameterized using mobility isn't right because we don't see deaths increasing. Except we do, we just see them increasing later. So what is it that's happened? Is there something else, some process, some randomness? Is it cases are so low that we're just waiting for an opportune moment when people head back indoors for things to spark and go off? And that's a question that I think is still an open question. Okay. I think I'm going to skip this last one. Oh, no, I want to show the picture. Okay, so here's the lesson, but let me show you the picture first. So I was talking about whether or not the time varying reproduction number, this is not real data. This is using Italy as an example, but it's data that is simulated data. Should the time varying reproduction number have a stepwise change parameterized by a step function, 0, 1, or should it be smooth, some sort of S-curve? Or should it be a mixture of them? Smooth, because people are changing behavior, and then government mandates that you stay home. And any of those are plausible. Yeah, a priori, any of those are plausible. Well, let us take samples from the prior. A priori, we think they're plausible. Let's look at how infections, which we don't observe, recall, look. Well, they're a little bit different, but the confidence intervals all overlap. And so, it might be hard to distinguish them, but maybe if we had really good case reporting, we might. But we don't. We're basing things on deaths. Here are the death curves. Again, this is simulated data. If this is the shape of RT, then this is what the death curve looks like. If this is the shape of RT, this is the death curve looks like. If this, okay, but that means this is the forward simulation of simulated data. If we want to now solve the inverse problem, you give me deaths, can you inform me about which of these is most likely? Well, it's hopeless. Yeah, there's no difference between these curves. So that's something called identifiability. Is this practical or structural identifiability? It might be both. I think it's practical identifiability. The data doesn't actually help you to inform about the parameters that you care about. Well, it's also structural because this is a different structure for the model. And so that's something to keep in mind as people are arguing about which of these is right. This data is going to inform you. So you can use simulated data to check your models and check whether or not your model could distinguish, and then find out if it can't. In this case, you can simulate data from your models from the prior. Another thing to do is simulate your models from the posterior, and that's something that's very important. Posterior predictive checks, and here's the paper here. We were already doing that because that's how our model works. The posterior is when we fit the data, when we fit the model to the data, and then we make predictions of deaths. And so these are posterior predictive checks immediately, which isn't always true for other models, but for ours, we already have those there. So yeah, that's the third lesson. To think about your model, you should use simulated data, either from the model or from the model after you fit it to data. Okay. Now turning to variants. So alpha variant, December 2020, gamma variant, January, February 2021, delta variant, March, April, May, June, I guess June 2021. So sometimes you need a complex model to understand what's going on, and sometimes you don't. And it's hard to know in advance. Okay, so in December of 2020, I was on paternity leave, but my postdoc was working hard on characterizing increased transmissibility of the alpha variant, at that point called B117. Actually, B117 wasn't the name we were using. We were using Public Health England names, which I never actually learned. Anyway, Lots of different names for these things. Thank you to the WHO. They also got lucky in some sense because alpha, beta, gamma, and delta are the only variants of concern that have arisen. There's lots of variants of interest, so there's lots of other Greek letters, but those are the ones that we need to remember, and they happen to all be consecutive. So how can we estimate whether or not, and to what extent, the time varying reproduction number R, or R naught, indeed, is higher for this variant of concern, alpha, as compared to the wild type, the lineages that were circulating, not necessarily wild type, but the previous lineages circulating in this case in England, yeah? Well, we can look at our estimates of time varying reproduction number, R, and we can regress them on some measure of the prevalence of B117. And so don't worry about SGTF. This is some way of measuring the prevalence. It's a good proxy, at least it becomes a good proxy by the time alpha starts to take over. Okay, so that's one model, and it's just a linear regression. We just want to see is R higher or lower given estimates of the prevalence of the variant. Here's a slightly more complicated model, not that much more complicated, but it uses a disease transition model. And, you know, do we need a more complicated model? Maybe, maybe not. It's hard to know in advance. And so ultimately we did both. And this is something that we do a lot, maybe too much. We try everything that we can, and then we look for consistency across those. And so here's the picture. I mean, I think the picture tells the whole story. In 3 regions of England, during lockdown here in pink, in November and December, no one knew that there was this variant spreading. No one was looking for this, but there was this striking thing. In most places, lockdown happens and cases start to fall. Lockdown happens and cases start to fall. This big thick line is cases start to fall, except in Kent, yeah, in east of England, where this variant arose. Cases are not falling during lockdown. Cases are falling here, cases are falling here. Why? If we stratify by variant, non-variant, S minus is the alpha variant, or proxy for it, S plus is beta variant. This is the previous ones, wild type and other things. Then we see that actually the lockdown is strong enough to control the spread of the previously circulating variants. And so in every region, S plus, blue, is decreasing. And in every region, S minus, alpha, is increasing. This was not a strict enough lockdown to control the alpha variant. Yeah? And so by the time the UK comes out of lockdown on 12th of December, well, Kent is just going crazy. This is why my colleagues noticed that there was some real problem going on. But immediately Oxford, which was decreasing, oh, suddenly it's increasing. But it's not suddenly. Alpha has been slowly building that whole time. It just looks like it's sudden because it coincides with the date in which lockdown opens, and actually S plus goes up a little too. Why does S plus go down, the wild type? I've gone back and forth on this, but I'm now convinced by my colleagues that there is competition amongst these variants, and you can see that with Delta sweeping the world. So S plus, the people who S plus might have infected are being infected by S minus instead, yeah, by the alpha variant. And similarly here in north of England, actually there's nothing going on. There is no S minus practically, but there are some cases coming from other places, and by the time lockdown gets lifted, it goes crazy. And so let's compare R of S minus, R of alpha. The time varying reproduction number is above the one for the wild type in every single region of England. Yeah. And so that is very striking. That is what led to another lockdown on the 11th of January in England. And that lockdown controlled alpha, but alpha swept the world, right? Alpha was the variant that was going everywhere before. Other things like delta came in. And so, yeah, we have estimates from 2 different models, and those 2 different models agreed and changed policy. Okay, now let's talk about gamma in Brazil, P1. So this is a paper that I am not on from collaborators, Esther Sabino, who I mentioned, and this just was short, very readable. By all means, go take a look at it. And it's just had a couple hypotheses. What could possibly explain the fact that while previously maybe 3/4 of the city of Manaus, capital of Amazonas state, had been infected, lots of hospitalizations, lots of deaths, somehow there were increasing hospitalizations and increasing deaths in December. Oh boy, I'm missing the dates here. Sorry. So this is probably March and this is December 2020. There's a second lockdown, but of course it doesn't have effect on the deaths immediately. So how could this have happened if 3/4 of people were infected? There shouldn't be a big pool of susceptibles. The idea that was set out in this paper and that we immediately turned to trying to quantify was that P1 had different properties than the previously circulating variants, and in particular, P1 was capable of reinfection, or maybe it was just higher transmissible. And if it's higher intrinsically transmissible, then that means that the herd immunity threshold is higher. And so how do we know? Here we need a more complex model. We can't just run regressions to answer that question. So here are the results of the more complex model. So the data comes from sequences. So what proportion of 20, 50, 100 random sequences, what proportion of those specimens from people are, they're all positive for SARS-CoV-2, what proportion are positive for P1, almost 80%, versus not P1, the things previously circulating, only 20%. Well, P1 wasn't circulating in November, so it was 0, 0, 0, and then by December, we start to see it circulating. And so this is a statistical model fit to that proportion. That's a key part of our bigger model, which is the same as the model before, but elaborated to have 2 different strains. Here's the data. Well, no one was dying of P1 before P1 was introduced. Here's the date that we think P1 was introduced. And now suddenly all of these deaths, we're explaining all those deaths as P1 deaths. But we don't have direct data on that. We just have the death counts. Seroprevalence, so what is the cumulative number of people who've been infected? Well, this is data that we didn't fit to, so it's very reassuring that our curve fits that data. And so non-P1 is above 90% based on these estimates, which is very, very, very high. And so if non-P1 is above 90% and P1 is approaching 50%, that means that a lot of people have been reinfected. Yeah, and this was very controversial. This remains very controversial. People don't believe the estimates that we had here, and thus they don't believe that people have been reinfected. But you can't explain the data without reinfection, and so that's what's shown here. So the only way to explain this death curve without reinfection, well, if cross-immunity is 100%, that means no one's reinfected, is to have a huge transmissibility increase, 4 times as transmissible. R is 4 times as high for P1 as for previously circulating variants. And, in January of 2021, maybe that was possible, but we didn't see P1 sweep the world, and so it does not at all seem likely that that's the case. Delta is really, twice as, maybe more, transmissible as the original strain, and so Delta really has swept the world. Delta might also evade cross-immunity. So cross-immunity is protection from previous infection. And so cross-immunity 0 means that previously infected, well, there's no protection afforded by that. You can be reinfected by P1, and that's also very unlikely. And so the most likely situation is here, but this is a big posterior location. Cross-immunity is between 50 and 75, or really, 80 and 60. And the time varying reproduction number is between, well, just look at the marginals here, 1.2 and 2.5 or something like that. Yeah. So here we fit a very complex model, not the most complex model, but one that we specially built to be able to distinguish these things in order to make estimates of the immune evasion of this variant. So as I said before, sometimes you need a complex model, sometimes you don't. Next one. Okay. Now I'm going to tell you about big data. So this is from a forthcoming paper. First author is a PhD student at Oxford, Valerie Bradley, works with me. And we had this idea. We should check whether these surveys, there's lots of surveys out there every day, lots of political surveys, lots of market research surveys, lots of governments doing surveys of behavior to understand their populations. We should check whether these surveys are giving us accurate estimates for the percent vaccinated for vaccine uptake, and accurate estimates for other things we might care about, like hesitancy. What percent of the population is is hesitant to get a vaccine? What percent is willing? And these are all important numbers. But the reason that we might be able to check percent vaccinated is because there's administrative data from the CDC. The Centers for Disease Control in the United States knows how many jabs have been given out, how many times someone has rolled up their sleeve and been jabbed and been given a shot. It's American English. Now that data might have some problems. We can talk about that. But that data showed something like this. 50% of US adults had a first shot by April. Let's compare that to survey estimates. Facebook runs a very big survey in the US and internationally. We're going to work on the US survey, 250,000 respondents. Facebook said actually 70% of people had already been jabbed by then. And that's a very different number. Could it possibly be right? Facebook's number comes with negligible margins of error. So Facebook says it's 70%, and we are very sure of that. And for various reasons, we think, no, there's no way that could possibly be right. But is it just, well, Facebook's some weird biased sample of active users of Facebook? Maybe, but they claim it's representing the US population. A different survey from the United States Census Bureau, they have this experimental, they label experimental to their credit, household pulse survey, very big sample size again, also significantly overestimates with, okay, we can now see the margins of error, but they're small, almost negligible. They certainly do not cover the truth, if we think this is the truth. So there's something weird going on with these big surveys. The big data paradox says that the bigger the sample size, the surer you fool yourselves. And by fool yourselves, well, the uncertainty is just wrong. You're super confident about something that is wrong. Compare that with a more conventional survey. Ipsos is an old school pollster. They're running a survey for a news website called Axios. Their sample sizes are much smaller in comparison, but a respectable sample size for a survey that's supposed to be representative of the US adult population, n equals 1,000. Here you can see reasonable margins of error, which do overlap with the truth for 20 out of 21 surveys. And so, okay, something's going wrong at the end. So how can we understand why there are these problems? Why, as you get more and more and more data, huge sample sizes, are your estimates so wrong? And so a recently proposed framework from co-authors on this, from Professor Xiaoli Meng from Harvard, says that we can decompose total error, the estimate that we have from the truth, from the benchmark, which we hope is the truth, but we do sensitivity analysis on that. We can decompose that into 3 terms: data quality, data quantity, and problem difficulty. So as data quality goes down, error goes up. As data quantity goes down, error goes up. As problem difficulty goes up, error goes up. Okay, say that all again in the other way. Error goes down if you have better data. Error goes down if you have more data. Error goes down if the problem is simpler. Now, which of these is actually driving the total error? So here I've plotted total error. So just take the estimate here. Facebook says it's 72%. CDC says it's 60, subtract those, 12%. Those numbers aren't quite right. Actually, let's look and see what they are. 15 percentage points, okay? So that's just total error. So now let's do that decomposition that I just told you about. And this is actually a pretty easy identity to work out. So by all means, look at the paper that we cite from Xiaoli Meng. It's surprising to see it, but it's actually not, the maths isn't that hard. Okay, so how can we decompose that total error? Well, as it turns out, the data quality, this measure of data quality, and this measure of data quality is really interesting. It's the correlation between your likelihood of responding to a survey and your response. Yeah. So if people who are vaccinated are more likely to respond, that will significantly bias the estimates. If people who are vaccine hesitant are less likely to respond, that will potentially significantly bias the estimates. So we don't have one single explanation like that, but that's an example of what could be driving the high data defect correlation measure of data quality, this term here, and it's highest for Facebook. Even though Facebook, or not even though actually, precisely because Facebook has the biggest sample size. So it's not, this error is not being driven by the sample size. Now it's relative sample size here. So it's this weird units of square root of n minus n over capital N. So this is the US adult population, and this is the number of samples. So in fact, this is not 0. It's not like we have, really 250,000. It's the square root of the probability that you're in a sample. And I don't have that number in front of me, but I guess it's something like 25. Okay, so there is some contribution to the error coming from the Facebook sample not being fully the whole population. It's not like we have administrative data where we just ask every single person. Oh, CDC has that. But Facebook doesn't, certainly. Their sample is maybe 0.1% of the US population. Have that right. Whereas Axios Ipsos is much, much, much smaller relative. This is relative sample size, orders of magnitude smaller. And so that could contribute to the error. I mean, that's classically what we think about as that's what these confidence intervals come from, but that's not what's biasing this. That's contributing variance, yeah? So remember, that if, well, don't remember, let me tell you, this is in units of error, meaning it takes into account both bias and variance. Yeah, bias meaning how far are you from the truth, and variance meaning if I were to do another survey with the same sample size, how much might things move up and down? Okay, and then inherent problem difficulty, well, that's the same for every survey. That just says that, you know, there is some variance because it's a hard quantity to estimate when it's around 50%. It's an easier quantity to estimate when it's around 0.15%. So this decomposition tells us that big biased data sets, we need to really worry because we will be severely understating the uncertainty. Now we can turn this equation around and calculate the bias adjusted effective sample size. That is, if we were to run a simple random sample, a perfect simple random sample where we really go to 100 random US adults and ask them, were you vaccinated or not? What error would we expect? The error there would only be from variance. Yeah, if you run a sample of size 10, it's going to have more noise than if you run a sample of size 100,000. That's perfectly random. So we can translate from the n equals 250,000, n equals 75,000, n equals 1,000. We can translate that into an effective sample size of an equivalent random sample with the same amount of error translating from bias to variance. And so here you go. The Facebook survey is only as good under this metric. They would not like me to say only as good, period, but under this metric for this outcome, it's only as good as a random sample of size 100 at the beginning when it's sort of okay, but not great. Well, okay, it's pretty good there. And it's only as good as a sample of size 10 by the end when it's so biased. And that is upsetting to people who've spent a lot of time thinking about this survey. But that's life. I mean, you don't always get the right answer, and the important thing is to learn why. And so we hope that we are constructively helping to figure out why. And I don't have slides on that, but we can talk more about that. What I do have slides here are why it matters. So we know about uptake because we can ask the CDC. What we don't know about is behavior surrounding uptake. Are people hesitant, or can they not access it? Do they not have time to take off work to go get one jab and another? Are they afraid of needles? Are they worried about side effects? Are they unsure whether they qualify because they're an undocumented immigrant and they don't know? Because when you go to, I just tried it, when you go to Walgreens.com, the US drugstore that's providing lots of immunizations, it asks you for information that suggests, oh, I might need to be a US citizen for this, but it shouldn't. It shouldn't. It should make a lot clearer that every single US adult qualifies. There is no residency requirement, no citizenship requirement, no insurance requirement. So we don't know what's driving people not to get vaccinated. We would like to. And so we know that the estimates from Facebook are wrong of uptake. So we have to lower those. So that gives us 15 percentage points to play with because there's only 3 categories here. Either you're willing or you're hesitant or you've been vaccinated. So if Facebook goes down by 15 percentage points, then we need to increase by some fraction of that willingness and hesitancy. So we run 3 different scenarios using the data defect correlation, using that row in order to inform us how those scenarios should be numerically calculated. You could just sort of do this using a back of the envelope thing. You won't get something all that different. And so under a scenario in which hesitancy is what's driving the error, suddenly hesitancy jumps because all of the error from vaccine uptake goes into hesitancy, jumps from 16% up to 32%. That seems unlikely, but it's possible. If what's driving the error is uptake, well, same thing. Access, if access is what's driving it, 6% up to 20%. And that's a really important finding. Maybe these surveys, which are done online, are missing huge swaths of people in rural areas who are older, don't speak English, don't have access to the internet, who want to get vaccinated. 8% is what the survey estimated, but really 20% of people are willing. And if that's the case, you got to change your strategy. You got to focus on getting doses to people's doors. Yeah. Okay. So that was the big data paradox. The bigger the sample size, the surer we fool ourselves. I think I have taken out the slides on orphanhood, so I'll just show you the website. Yeah, I'll show you the website. So most recent work, other than Delta, which I don't have slides on Delta either. By all means, you should look at our Delta papers. These were very important and influential. papers trying to understand what in the world was going on with Delta, and on those, I mean, the work was done by colleagues, and that was important work. We contributed mathematical modeling, and I think that was important as well, but the central part of those papers was from people doing lab work, doing surveys, doing work on the ground, doing work in laboratories trying to understand Delta. Okay, so orphanhood. So we use 3 different definitions: primary, death of one or both parents. This is UNICEF's definition of orphanhood. Loss of a primary caregiver, so that includes parents or grandparents, custodial grandparents who provide care, and then loss of primary or secondary caregivers, so that's all the categories above, and then other co-residing kin, often grandparents. And so our estimates are not directly observed. These come from a model because we don't have direct data about children losing parents. What we have is data on fertility and data on deaths, hopefully by age, but in many countries we just have data on reported deaths. And so given both of those things, age-specific fertility and deaths, we can work out minimum estimates. These might be severe undercounts, but we can work out minimum estimates of the number of children affected, and the number is astounding. 3.3 million children at minimum have lost one or both parents, and losing both parents is rare just because of various epidemiological properties. So this is most often, I would say, 3.3 million children who have lost one of their parents. Now, it could be that they have lost a single caregiving parent. In many countries in the world, care is provided by grandparents or provided by mothers. So this is potentially a catastrophic thing for children. And so, yeah, I mean, I don't have too much more to say about this. I would very much encourage you to read this paper and the policy report that goes with it. I will put those links. Hopefully we can add them to the YouTube at the bottom. So here's the paper, global minimum estimates, and here's the policy report. And we are really trying to bring more attention to this issue. I think that children have been overlooked. The experience of children has been underappreciated, and the epidemiological properties such that COVID is supposedly a mild illness for children, I'm putting that in quotes because, indeed it's great that children don't often die, although they do sometimes. That's been used as like a political football in terms of arguments about things like school closures and non-pharmaceutical interventions. And something that is really why we called it the hidden pandemic is that if you have 3.5 million children affected by something catastrophic, immediate, and long-lasting, right? These children are now growing up without parents. Well, that's going to be a huge, long-lasting problem for the world. And it's something that we know, that's why we have a policy report here, we know a little bit about evidence-based policy to address this because it's happened before with, of course, different particularities, but HIV, AIDS orphans are something that my colleagues, this is how this all worked all outside of this, they had worked on that. So yeah, let me leave you with a plot from this. So in 2020, 1.8 million reported COVID deaths. Now we know that the true toll is a lot higher, but that's how many deaths were reported. And 0.9 million affected children. That's our global minimum estimate. That's in the first year. Already by the end of May 2021, that's doubled. 3.6 million reported COVID-19 deaths, but the true toll might be orders of magnitude higher, 10 million, and 1.8 million affected children. And this is before Delta surges, before we were able to refine our estimates for countries like India that had huge underreporting. And so this is all under estimates, minimum estimates. Okay, so to conclude, there's code online. All of the stuff that I've told you about is reproducible. That's been very important to us. And people have built on it as a result. You can go back to, let's look at the first release. Italy, well, I told you about Italy, that's not the first one. Version 1, replication code. What date was this? March 29th, reports released on March 30th, yeah. And so, people have criticized various things about our model, but it's all here. The reason they've been able to criticize it is because they've been able to download it and reproduce it. That's been very important. There's also now an R package. All of the other papers have code on GitHub as well. So by all means, if you're interested in any of this, don't just take our word for it. download the code, try it yourself. Thank you so much.
Thank you so very much for this talk. I think we all were rather mesmerized and at the same time terrified by the implications of your work, and for instance, regarding the orphanoid component was chilling to hear, honestly. Now, I don't know if anyone has any questions. I have some,
Yeah.
but if some of you want to ask them first, I'd be very happy to hear them.
I have one. So I'd like to congratulate you on your work during this pandemic. And I'm so happy to see the Star Sabine collaboration because I'm Brazilian and alongside her, Jaqueline Góes has doing a grateful and amazing job on this pandemic. And I follow it a lot. And it's so happy to see that you are collaborating with her. And I'd like to know more about the challenge you have on this work in Brazil. And because I'm opposition of this government and I'm part of Workers' Party, and we fight a lot against this negationism, and the government doesn't matter about lockdown, about vaccination, and it's so sad. And I'm not in Amazonas, I'm from South, but every country is so affected by this policy, which doesn't help in any factor of the scientific research, of health, of education. So I'd like to know what's your point on your research here?
So I'm just pulling up just some of the papers to sort of show you our involvement and how, I mean, it's been the most fascinating country, not necessarily for good reasons. So this report was done in April, finished up at the beginning of May of 2020. And at this point, the conversation in Brazil happening in the parliament, there were these claims from shoddy work by economists, I think, that the epidemic was over, it was under control, and that just was not true. So here is the report as of May, and I don't think we show results for every state, although I think we ran them. Maybe we only ran them for these states that were hard hit. And so already Amazonas state was attack rate, meaning what percent of the population was infected, we estimated 10%, which is astounding. In no state was the epidemic under control. Yeah, and this is at a time when people were opposing lockdowns, the president, and when there was this, belief like, no, it's already over. Brazil's special, younger population, blah blah blah. And so, yeah, I mean, it's the same model, but like interventions work, and you can see them. This is parameterized with mobility, but they were not strong enough to control the spread of the epidemic. And so that's why the time-varying reproduction number is above 1. So that was May. Brazil is also fascinating because it has such a big and, in some sense, well-funded and developed public health systems and private hospitals, but they're also part of the health system, as I understand it, in terms of reporting. And so, unlike the UK, where data sharing is hard, although the data is in a database somewhere, you need to have special permissions. And of course, there's ethical issues. So there's good reasons that you need to have those permissions. But even so, even if you're the right person with the right connections, you might not be able to get the data because just data sharing is hard. In Brazil, there is the CYWF, Sistema de Informação, sorry for my pronunciation, de Vigilância Epidemiológica de Gripe. Okay, well, it's not gripe anymore, it's not flu, but this database is a huge database, and it's something that researchers outside Brazil without any particular access can get access to. And so this is information that was available in Brazil. Now this says 25th November, that's when it was finally published, but we did this work earlier, and we were able to characterize things at the state level, 26 different states, which previously, there have been big papers about this for France or maybe for England. I don't even know if the English papers were out yet. And so Brazil because it's a big country, because COVID wasn't under control, we were able to characterize things like what is the onset to hospitalization distribution. So someone contracts COVID, SARS-CoV-2, they're infected with it, it develops into the disease, COVID, they're admitted to the hospital. How long does that take? And so we have estimates that are varying. And so that was, I think, important work that we did. Do you have a good picture to show you? I think I have one good picture. Yeah, there we go. So the distributions vary based on the state that you're in. And so let's find Sao Paulo.
I'm just like finding my state here.
Okay, what is your state again?
Paraná, it's PR.
PR, yeah?
Yeah.
I don't see it. I don't see it. Paraná State. There, PA.
No,
So you're
no,
right.
PR.
PR?
Yeah.
I don't see it. Did we not do it for some reason? Oh, there we go, PR.
Yeah.
Yep. So onset to death is longer. It's the 7th longest. You know, it's hard to interpret exactly what this means. We tried to do regressions based on things like measures of poverty. Other people have since done better jobs with that with other types of measures. But there it is, you know. Yeah, I mean, very, very interesting. There's PR, one of the shortest for onset to admission. So maybe that means that good health care, people are getting into hospital quickly. Yeah. I don't know.
I think about health in Brazil. We have a public system, and everyone has access. And it doesn't work a lot in some states, but especially in Paraná, I think it's a good health public system. And I think our state government now is caring more about the vaccination. I think we are the 5th with more vaccination. And also I think now this time he are caring a little because next year is election, and so he needs to show some data. But the opposition work of politics also help to combat, and I think that's like a conjunction of work in statistics and the politics and the health. So congratulations for your work more on time.
I will mention one more paper. Well, this one I already talked about at length. This is the one that was the first one to characterize P1 gamma variant, published in Science. I think pretty readable actually. So have a look at that. But one thing I forgot to mention, because it's new and I can't keep track of everything, is looking at spatiotemporal changes in hospital fatalities. And so this is a story about healthcare overload. Full credit to colleagues here. I'm somewhere in the middle on this paper, having not been that involved, but let's just show one figure. So weekly in-hospital fatality rate, well, of course it varies by age, and so that's what you can see, but it also varies by week, and so this is hospital rate is higher, fatality rate within hospital is higher, and presumably that's because of overload. So this is a very interesting story. I'll just give you the title of that again. Okay, so yeah, thank you for the question. Other questions?
I think we have Om also with a question. At least he has his hand up.
Yeah, so actually, when I was talking about you with one of my friends, like way before the talk, so like he went to your web page and read about you. So actually, he had this question for a long time, and today he could not join because he had some issues in his family. But the question is, like you are working on such a significant mathematical stuff, which has such a big real life meaning. So how do you actually convince politicians who usually do not have the needed mathematical competence to understand the meaning behind your data analysis? So I think that's a very good question.
Let me make sure I got it. So the question is, when communicating this with politicians, but also policymakers, what is the way to do that if they're not mathematically? Yeah. Okay. So I mean, you have to be smart in various ways to be a policymaker or a politician. And, you know, if we disagree with people's politics, we might assume that they're not. But you have to have some amount of specific intelligence, probably not necessarily technical. And so it's intelligence and specific knowledge that as a, you know, scientist who doesn't have to make policy decisions like I don't have or have to worry about. And so things need to be simple, period, because dealing with complexity that then says, well, you know, here are 10 different things and we don't know anything about any of them, basically, uncertainty intervals are all like this, doesn't help. But connecting the findings, translating them into language and into policy relevant language, yeah, it's not easy, but that's what you need to do. And so, for example, when we were talking with the United States, with people in different states advising state level response about our work in the US, we were emphasizing, like, you know, what we saw with Italy, and in some sense what we could have done a better job, what we got wrong, which was, you know, things are closed. We were talking to people in April, things are closed, but, you know, you're opening up already and things are starting to look bad. Like it's starting up again. And this was what I don't think we've conveyed as well as we could. And it's, you know, still a mistake people make. If you have 5 cases per 100,000, not that many cases in some sense. If you have 10 cases per 100,000, you feel like, oh, well, you can just wait around. 5 cases. Okay, next week, 10 cases. Okay, next week, 20 cases per 100,000. No, you can't wait around. That's exponential growth. That's doubling every week. And so, yeah, I think that early on that was a real challenge for communication. More recently, and this is something that I have seen with colleagues who are much better at this and talk much more with policymakers, communication is around what we do know and what we don't know. And so politicians want us to know everything and want to just, you know, we go out and measure it, find out what's the answer. And in fact, we don't know the answers to lots of questions, as I showed you with the vaccination uptake, with those big surveys. We would like to be able to, and people are using the data that we have questioned in order to come up with a ranked list of here are the localities within the United States that are the most vaccine hesitant, or here are the groups that are the most vaccine hesitant. I don't think we know that often. I don't think that we have a good handle on that. And so, well, we need to be able to focus on what it is that we can focus on and what we do know about. And so I would argue, based on our work, but also based on, you know, people who think about these sorts of issues from the perspective of vaccine hesitancy, but also willingness, it doesn't necessarily matter if we can give a ranked list of who are the groups or where are the places that are most hesitant. What matters is, are we breaking down barriers? Are we doing what we need to do, which is different in different communities, in order to address both hesitancy and willingness? And, you know, you see, I just read a nice short piece about Puerto Rico, which is, of course, an island, and so had some advantages over a place like New York City that was not an island. But Puerto Rico is not a Pacific island that's unconnected. There are international flights landing there every day. The public health system in Puerto Rico did a better job, has a higher vaccination rate, did a better job of reaching people than almost every other state in the US. And you can see that in the effectiveness of them not having bad outcomes in the most recent wave, which was, you know, the wave in the US that was in some sense the preventable wave because vaccines became available. So yeah, I think there's a lot to learn. Politicians, policymakers. I mean, my work, you know, I was talking at some point, there are politicians that I've talked to, but it's more about talking to policymakers and sort of their technical advisors. That's who I have the most experience talking to. And so those people are technically minded. And so it's a matter of figuring out, well, how are they going to end up translating these things? What's the key thing? And so, for example, with our work on variants, the key message that we really wanted people to take home, and I don't know that we ever succeeded, was it's not just about increased transmission, it's about immune evasion of prior infection. And so you can't just assume we had a big wave in Mumbai or Delhi in the autumn, so we're now protected. That's just not, as it turns out, how this virus and new variants of this virus works.
Yeah, thank you so much for that. That was a really insightful answer, and really showed how tough of a job you and your colleagues have done in the past year. And so once again, on the behalf of all the humanity in the world, thank you so much for that. And I just had another question. So your research interests are very diversified. Like you work on mathematics as well, and on CS and stuff like that. So how did you end up with such a diversified research field?
Yeah, I mean, this is, in some sense, a lack of focus. I don't necessarily recommend it for everyone, but being very open to collaborations and working with collaborators who have interesting and exciting problems. And so, I have a background in computer science and mathematics, and that has taken me to statistics. And as the famous statistician John Tukey said, paraphrasing, being a statistician is great because you get to play in everyone's backyard. And so I have taken what it is that I know and then worked closely with people who are scientists who work in all sorts of fields. And, you have to have some humility here. It's not that I can solve their problems for them, but I can help them formulate their problems in a statistical, mathematical way, and then come up with solutions that I know how to come up with. But ultimately, the final arbiter is science, is not statistics or machine learning. And so it's always a conversation. And doing methodological work means that you get to have that conversation with lots of people.
Yeah, thank you so much for that. And yeah, once again, thank you so much.
Thank you for the opportunity. And I think let me know when it's posted on YouTube. I'll send you some links to papers to put into the description.
Thank you.
Yeah, sure, absolutely.
Thank you so much once again.
Yeah.
We're reaching the end of this this lecture and transmission, also this part of the questions. Just have one last question, which is related to how, for instance, a continent like Europe, which has been mostly vaccinated by this point, will face this next winter. How do you see it? You're not a futurologist. I don't want you to do any sort of futurology. My question would be more, how do you expect people to react at this next wave that are likely coming? Do you think that we've learned anything at this point?
We've learned so much, and we've come so far, and there have been such amazing advances scientifically, and there's been so little progress from a behavioral science, psychology, political science. I mean, we're not in it together. We should be. That should have been the way that that this was the opportunity for the world to come together. But you have Europe using the booster, using vaccine, using excess surplus vaccine for boosters, which boosters save lives. Boosters are very effective, and at the same time, you have vaccination rates below 5% in countries in Africa. We haven't come together. There's amazing treatments that are going to become available if someone gets diagnosed quickly, but those treatments again won't be available in the global south anytime soon. And even if they are, you need rapid testing to be able to know when you should prescribe those things. So what does the winter look like in Europe? Not great. Austria is ahead of the curve and already brought in a lockdown for everyone. But there's always hope. There's always, it's not like we should be pessimistic. There are low cost and real mitigations that governments eventually will finally turn to, because they have to, because our understanding is finally coming around to them. a lot of COVID transmission is airborne. So ventilation needs to change dramatically. It just needs to. We just need to find ways of getting fresh air, or if it's impossible to get fresh air, clean air through filters into indoor spaces. It just has to happen. And it's, 2 years too late for COVID, for this pandemic, but in some sense it's decades too late, because our understanding of transmission of respiratory diseases is only now catching up, and we're realizing that. I don't work on this. I'm an informed consumer of science on airborne pathogens as respiratory transmission, but I'm very convinced by colleagues who do work on this. Same thing goes for mask usage, right? But none of that's enough. People are going to need to work from home in countries that otherwise their healthcare system will be overwhelmed. But the main problem as a world is vaccine inequality, and it's appalling. It's appalling the way that the first world has scarfed up access supply, and it becomes excess. Doses expire of AstraZeneca. I just read an article about doses expiring in England. It's a tragedy. So yeah, I don't have a good prediction for you, nor are we leaving this on a hopeful note. Vaccines are becoming approved for younger and younger ages, and though again there is this issue of equity, some countries will and are moving quickly to vaccinate younger populations, and it's an open question what the effect of that on transmission will be. But I am hopeful that will allow countries to get closer with other interventions in place as well, like masking and ventilation, get closer to controlling the epidemic through both pharmaceutical and non-pharmaceutical interventions.
Thank you very much. I was not expecting it to be a hopeful end of the session, but well, it's better to face the hard truth than a beautiful lie, I guess, and to really look at the data and be able to extract conclusions from it that actually saves people's lives. It is really the work that you've been doing, and that we really applaud, and we would like once again to thank you all, and all the data scientists and mathematicians and even other kinds of scientists that have really all worked on this exhausting area of research for the last 2 years. Yeah, a thank you to all of them, and to you for giving your time to speak here with us. Thank you once again.
Okay, thank you so much.
Thank you.